Now, should Medicare change in some fundamental way, the way that providers are paid in a way to accelerate the momentum to do more of that?
So my answer to that's yes, and in fact, Medicare is in the process of doing that in ways that I think still need a lot more development. But from a broad picture point of view, the current Medicare system pays providers in a very fragmented fee-for-service way, and there's an enormous amount of waste that gets incented within that type of system. And I think more to the point, um, the incentive for individual providers or provider organizations to be efficient doesn't exist. So providers don't have an incentive to adopt programs that are costly to implement and may keep people away from the doctor or away from the hospital because, of course, they get paid when people, under the current system, they get paid when people go to the doctor or go to the hospital. So new payment models which pay in some sort of global budget way or global payment way enable providers that are efficient to capture some of the fiscal benefits of being efficient. I don't want for a moment to make it appear like this is a panacea for our healthcare system problems. There's a lot of organizational challenges that such payment models create, and there's concern that providers will provide too little care as opposed to too much care. So quality measurement becomes exceptionally important in this world. But when you compare the alternatives of a fee-for-service system that's fragmented and no incentive for efficiency and well-known deficiencies in quality to a system where providers are held more accountable with incentives to both be efficient and, if implemented well, improve quality, I think that the latter approach likely is a better long-term strategy than the approach that we've been on because it is just so difficult to get the prices right for the vast number of services that we're paying and across the vast number of sites of care that are delivering those services.
Now, let me ask you a question, though, especially because many people have seen this article by Stephen Brill in the latest, I think it's the
Right.
cover of the latest Time magazine, where he looked at basically the prices that are paid and how
Yes.
and much of what you were just describing and much of our whole conversation is basically about more efficient controlling costs by reducing wasteful use of services. We haven't really talked much about how much is paid for that in the unit price of that MRI or of that whatever that service is done.
Right.
Whereas it seems to me that countries that have controlled medical care costs have really put a lot more pressure on prices than the United States is.
Yeah, and certainly we could do that. And of course, in Brill's article, he notes that Medicare, our public payer, has in fact achieved lower prices than many private payers pay. In fact, a lot of that article is talking about the prices that are paid by a relatively small number of people that don't have insurers shopping for them. But the premise of your question is true that we tend to pay more in the United States. And of course, as an economist, it would be wonderful if we could get more and pay less. But my general sense is that um, the uh, efforts to achieve efficiency can't and won't achieve if all we do is slash our payment rates. There's a bunch of other reasons in the United States why we pay more. In fact, we pay more for a whole series. Professors get paid more,
Well,
highly educated people.
I find that to be an excellent policy.
Yeah, right. The uh, uh, the entire returns to education in the United States tends to be higher, and of course, we put a lot of burdens on our providers as well. So I think a strategy of constantly cutting prices is one which sounds wonderful, but I'm not sure that we would be able to live in the current environment for the type of care that we want if we just slashed prices. And I think that a world in which you give provider systems the incentive to purchase care efficiently. So you're always going to find examples of things that are overpriced, but of course you'll find other examples of things that you might consider to be underpriced. And part of the problem is the goods that we're buying aren't really the goods. The thing that we care about is the health of a patient for a period of time or the success of treating a particular condition. But we tend to purchase our anesthesia separately from the way we purchase the surgery, separately from the way we purchase the hospital who was had the OR separately from the 3 follow-up visits and the several other things that are going on. We have this very fragmented system, and it's easy in that system to get the prices wrong. Even in Medicare, there's reasonable evidence that we don't get the prices right, although, as the Brill article would point out, we do pay a lot less in Medicare.
But
But
I'm sorry,
go ahead.
finish it. Well, I mean, it does seem to me that. Well, let me ask you a question. So, how do we deal with the uh, one of the reasons why we pay high prices for some things. If you think about, say, where, in your neck of the woods, Partners has such incredible prestige and market power and sort of social standing that they can really charge pretty high prices. And it does seem to me that some sort of countervailing pressure from the demand side has to be part of the.
And of course, well, there's a reasonable case for pressure from the demand side and some type of price regulation in various ways. And of course, in Massachusetts, there's a lot of attention to that. But Partners provides an excellent service. They're considered quite high quality, and we could have a long discussion, which I'm not prepared to have now, about whether they're worth the extra money or not. But the broader point, I think, is as long as you're setting prices for individual services, it's very hard to tell. For example, if you were to look to see an organization that was charging more for a knee replacement, you might want to say, well, let's pay less for a knee replacement. But if the organization that you're paying less to requires you to come back for a redo more often, then it's problematic. Or you don't know if the knee replacement was needed anyway.
Yeah.
So there's a lot of different challenges. One advantage of changing the nature of payment as opposed to just the payment rates is it allows you to set your payment in a manner where you're purchasing something more closely to what we want from the system, which is health for a person with a particular medical condition or health for a person over some particular period of time. And the issues of market power, certainly outside of Medicare, are certainly important ones. And we have a long way to go to figure out how we want to deal with that type of market power. And I think we're going to see a lot of pressure placed on providers and their prices, at least their growth in prices over time. But even if we could get the prices exactly right, I'm not sure we would do ourselves a lot of favors if we maintained the general fragmentation across the entire system.
Mm-hmm. By the way, my stepmother had a bypass at Mass General, and she $72,000, which was a pretty impressive price. But I must say that she
charge or price?
What's that?
Was that the charge or the actual amount that was paid?
I believe that it was the charge.
So, right. So depending on her insurance company, of course, the price could be a lot less. But nevertheless, go on.
But one of the things that struck me was that she did feel that she got beautiful care, and as she's and she's in her 80s, and it's been a tremendous boon to her peace of mind, knowing that she basically feels like she's got some of the best health care in the world backing her up. And I don't think that and there is that. It's funny. I think the public conversation about health care. The fact is that we really have a tremendous amount of respect and admiration for the work that's done to repair our hearts and things like that. And we tend to view the insurance companies as kind of the bad guys in a lot of the public conversation. And one of the issues around cost control is, at some level, we have to make some trade-offs, and we really don't like to talk about that. We like to talk about...
No, absolutely. And that's of course, what economists do, is they focus a lot on trade-offs. And I would say that, first, I think insurance companies have been excessively vilified. That's not to justify all the things that insurance companies have done. But the issue of prices, for example, that you were talking about earlier, is not an insurance company issue as much as a healthcare provider system issue. And of course, the healthcare providers are the ones that are delivering the care that we want them to deliver, although, of course, not always as efficiently as possible. And we want to try and maintain the highest quality of care at the lowest possible price. But again, that's an easy thing to say when I'm talking to you in a blog. It's a hard thing to manage, even amongst quite well-meaning people. And so the challenges are that we recognize that for a whole range of reasons, the government doesn't do a particularly efficient job when they try and intervene in a whole variety of ways. And we could talk about pros and cons of government managing of things. On the other hand, the private sector as well is subject to a number of inefficiencies that we could discuss at great length, including high prices, which you've mentioned. So inevitably, there's going to be some sort of balance between public and private roles, and there's going to be some role for regulation and some role for markets, and there's going to be some trade-off between, as we started, very expansive benefits that allow providers to do what they want and pay for it, removing anybody's incentive to be particularly cost-conscious, and a sense in which we're overly cost-conscious and people are being denied care that we really think is important. And because health is so complicated with thousands and thousands of services, each of which may be appropriate in a whole range of different clinical conditions, it's nice to think we could micromanage what happens, but my personal opinion is there's just no way we're going to micromanage what happens. What really is going to matter now and in the future is going to be the decisions that physicians make at the bedside. And our job is to set up the system that surrounds those bedside decisions to make sure that providers have the incentive to provide the right care at a decent price, but not more than that and not less than that. Again, that's a wonderful soundbite because I use the phrase the right care, and of course, it's very hard to define exactly what that is. So we're going to end up setting systems that hopefully will do a better job in the future. But it's a non-trivial task.